Welcome to Radiology Made Easy. Today, we'll be discussing an interesting case involving multiple subependymal foci of calcification. This is an axial image through the level of the thalami and head of the caudate nuclei from an unenhanced CT study of the head. There are multiple subependymal foci of calcification. No other abnormality is visible on this slice. The appearance is nonspecific and could be due to old infection, such as cytomegalovirus or toxoplasmosis, or secondary to a condition such as tuberous sclerosis, although there is a wider differential of more rare conditions that could also give this appearance. These are selected axial images from an MRI study of the brain. There are multiple small subependymal nodules. On the flare, fluid-attenuated inversion recovery images, several cortical and subcortical foci of high signal are evident. These are likely to represent cortical tubers. I note a septum cavum pellucidum, which is a common incidental finding, but I am not aware of any association with the likely diagnosis of tuberous sclerosis. I cannot see any complications such as a subependymal astrocytoma on these images, but would of course review the whole study. So our diagnosis is tuberous sclerosis without identifiable complication. Intracranial calcifications are usually pathological in children, but are more often physiological with increasing age. Calcification of the pineal gland may be seen in the under 20s and is increasingly common with age, along with calcification of the dural reflections, arachnoid granulations, choroid plexus, and dentate nucleus of the cerebellum. However, calcification of the basal ganglia suggests hyperparathyroidism or Farr's disease. The differential diagnosis is extensive, but may be ordered with a simplified surgical sieve. Congenital causes include tuberous sclerosis with subependymal and/or cortical hamartomas and Sturge-Weber syndrome with gyriform lesions. Acquired causes include dystrophic calcifications associated with trauma from injury or previous surgery, ischemic insults, and previous radiotherapy. Inflammatory causes include sarcoidosis with leptomeningeal, periventricular, pituitary, or pontine calcifications, and systemic lupus erythematosus with calcifications in the basal ganglia or cerebellum. Infective inflammatory causes may be congenital, such as torch infections with periventricular and/or subependymal calcifications, which may resolve with treatment in the case of toxoplasmosis, or congenital HIV with periventricular frontal or cerebellar calcifications. Acquired infective causes include cysticercosis associated with calcified cysts in ventricles, basal cisterns, and at the gray-white matter junction, tuberculosis, cryptococcus associated with parenchymal or meningeal calcifications, and HIV associated with calcifications in the basal ganglia. Neoplastic causes include those tumors which commonly calcify. Intraaxial lesions include oligodendrogliomas, up to 90% of which calcify, and low-grade astrocytomas, while extraaxial lesions include meningiomas and pineal gland tumors. The incidence of spontaneously occurring tuberous sclerosis is similar to that of inherited autosomal dominant tuberous sclerosis. The classic triad of findings is adenoma sebaceum, mental retardation, and seizures. However, all three may only be found in 1/3 of cases, and multiple other features may be identified, including subependymal nodules, cortical and/or subcortical tubers, cardiac rhabdomyoma, angiomyolipomas, ungual fibromas, retinal hamartomas, and subependymal giant cell astrocytoma. That's all for today's case. If you found this video helpful, please like, share, and subscribe to Radiology Made Easy. Thank you for watching.